Hi everyone, and welcome to my channel and another video about clinical pharmacy practice. In today's video, I'm planning to talk to you about hypertensive emergency management and how to differentiate hypertensive emergencies from hypertensive urgencies in clinical practice. They are very similar, and we see both in clinical practice a lot. And the management of each one of them could be different, and I'm going to explain to you how do we manage it here in North America, and then we can have a discussion about how do you manage it wherever you practice. Now, if you're new on my channel, this channel is all about clinical pharmacy practice. If you are planning to become a clinical pharmacist or you want to advance your career, make sure to subscribe to the channel and activate the bell so that you get notified of my future videos. This channel will definitely help you. Now let's get started with today's video, and as usual I have a case for you. This 55-year-old female patient is admitted to the hospital for the management of a high blood pressure. Her blood pressure on admission was 230 over 120, and she appeared confused and complained about chest pain. Her past medical history includes hypertension, coronary artery disease, and diabetes mellitus type 2. Home medications include amlodipine 10 milligrams daily, hydrochlorothiazide 25 milligrams daily, atorvastatin 40 milligrams daily, metoprolol 50 milligrams twice a day, and metformin 1000 milligrams twice a day. Her daughter brought her all her medications in, and while you're checking her medications, you notice that the bottles were empty and they were last dispensed 4 months ago for just a 1 month supply. Chest x-ray revealed pulmonary edema, and her ECG showed ST segment depression. Laboratory tests showed serum creatinine of 6.5 milligrams per deciliter, BNP of 1250, and an elevated troponins. The ERP, that's the emergency doctor, would like your assistance to choose a medication to manage this patient's hypertension. What would be your recommendation? Restart her home medications. Give IV nitroglycerin with a goal MAP reduction of 25% within 1 hour. Give her sublingual nifedipine with a goal MAP reduction of 20% within 1 hour, or give her IV enalaprolate with a goal BP reduction of 50% within 1 hour. You see, all the options, or at least 3 of them, are very similar. Different drugs are used, but the goals seem very similar. The first one is restart home medications. And why do you think we have this option here? Okay, let's go back to the case. The patient was on amlodipine, hydrochlorothiazide, and metoprolol for her blood pressure, probably, and also the CAD. And when you checked her medications, you found that all the bottles were empty. All the bottles were dispensed 4 months ago and only for 1 month supply. That means the patient probably took that 1 month supply, used the medications, but never refilled her medications for the last 3 months. That means she was out of her medications for 3 months, and she hasn't been using anything for her to control her blood pressure, and that's probably why she came in with a hypertensive emergency today. Okay, so we're gonna come back to the case and solve it together. But first, let's talk about hypertensive urgency and emergency, and what are the differences between both, and how do we actually treat them in practice. So hypertensive emergency is actually acute marked elevation in blood pressure that is associated with signs of target organ damage. These signs could be pulmonary edema, cardiac ischemia, neurological deficits like increased confusion, acute renal failure, aortic dissection, eclampsia, anything like that. It could be something else too. Any signs of end organ damage, plus an acute and markedly elevated blood pressure defines hypertensive emergency. While on the other hand, hypertensive urgency is also marked elevation in blood pressure, but without evidence of end organ damage. So a patient would come in with acutely elevated blood pressure, systolic blood pressure over 220, but they don't have any signs of end organ damage. Kidneys are fine, liver is fine, everything seems to be working fine. The patient is not confused and is asymptomatic. So those patients are considered a hypertensive urgency. All right. Now let's move to the next slide. Continuing with definitions here, with hypertensive emergency, it basically requires immediate blood pressure lowering to prevent or limit further target organ damage. So that's our goal here, to limit or prevent any other organ damages. And in hypertensive urgency, blood pressure reduction occurs over several days and not necessarily immediately. Because the patient is asymptomatic, they don't have any organ damage, so we can take our time to lower the blood pressure over several days. Goals of therapy. In hypertensive emergency, usually the goal would be to lower the mean arterial pressure, the MAP, by 20% to 25% within the first 1 to 2 hours. And we usually use IV medications for those patients because, like we said, from the name, it's emergency, so we have to do immediate lowering of blood pressure to control the organ damage and avoid spreading organ damage to other organs. While in hypertensive urgency, we lower the blood pressure by about 25% in the first hour, then to 160 over 100 blood pressure in the next 2 to 6 hours, and then we lower it to the normal blood pressure over the next 2 to 3 days. And in hypertensive urgencies, we usually use oral medications as opposed to IV medications in hypertensive emergencies. So you can see that the goals are different between both, and that's again because of the because of how emergent hypertensive emergency is, and due to the end organ damage, basically, which we don't see with hypertensive urgencies. Commonly used IV medications that we use with hypertensive emergencies are sodium nitroprusside, nitroglycerin, hydralazine, enalaprlat, phenoldiprem, nicardipine, clofidipine, esmolol, and labetalol. And all of these are IV medications. Okay, keep that in mind. We're not talking about patches, nitroglycerin patch. We're not talking about oral labetalol. No, we're talking about IV medications here. These have been trialed in so many clinical trials and have been proven to be effective in lowering the blood pressure really quickly to our goal in cases of emergencies. Now, each and every one could be preferred in different if there are different comorbidities, such as, for example, a patient with extremely high blood pressure, hypertensive emergency, and maybe stroke. They would go for something like a calcium channel blocker, like a nicardipine, or if a patient has severe damage to their kidneys, they would avoid sodium nitroprusside because it can accumulate and cause cyanide toxicity in those patients. So if the patient has comorbidities, you get to choose from these as you go, as the patient would benefit. Now, oral antihypertensives that we use in hypertensive urgencies usually are captopril, clonidine, nifedipine, and labetalol again. But bear in mind that we don't use nifedipine sublingually, which has been the case in the past. Like years and years ago, they used to use nifedipine sublingually. This is not an option. So if you will use it orally, you will have to use the oral tablets or capsules, whatever formulation you have, but not sublingually. While if you need a sublingual quick-acting oral antihypertensive, you can use captopril here. This is the only one that we have in North America that can be used sublingually. I don't know if you have other medications wherever you practice that can be used sublingually, but captopril is the only one available here that can be used sublingually. Nitroglycerine sublingual tablets are not an option here. So not for hypertensive emergencies or urgencies. So those can be used for an acute angina attack, but not for the sake of hypertensive emergency or hypertensive urgency. And that's why I did not include it here. All right, so this is basically, so now we know the goals. What do we need, and how low do we need to lower the blood pressure? Always remember this one. We target a MAP lowering of 20% to 25% in the first 1 to 2 hours for emergencies. And for urgencies, we target a blood pressure lowering of 25% in the first hour, and then 160 over 100 in the next 2 to 6 hours, and then to normal within 2 to 3 days. So always remember this goal. And now let's go back to our case and apply this information. So this patient has been maintained on certain medications. She was not compliant in the last 2 to 3 months on her antihypertensive medications, and now she's coming to us with really high blood pressure, and the doctor wants to know what to use for her. Should we just restart her whole medications, which is obviously a case of non-compliance? Shall we treat her as a hypertensive urgency and maybe restart her whole medications? Or shall we start IV therapy with one of those two? Or shall we give her sublingual nifedipine to lower the MAP by 20%? So the blood pressure is quite elevated, and there is evidence of end organ damage here that can be seen in the increased confusion, in the acute kidney injury, and in her chest pain and the ECG changes. And let's go back to confirm that. Blood pressure elevated, we know that. She appeared confused, so there is a CNS confusion. There is a chest pain. And what else is there? Let's keep reading. There is pulmonary edema that could be also a sign of organ damage. ECG showed ST segment depression, so there is ECG changes, and troponins were elevated, and the BNP is also elevated. So all of these together tells you or tell you that there is organ damage, and several organs now have been affected. So this should be treated as a hypertensive emergency, not a hypertensive urgency. So if we determine that this is a hypertensive emergency, that means we have to treat it with IV therapy, not with oral medications. So restarting her medications is not going to work right now. Maybe it's a future plan, but not right now. Right now we need an IV drug. But which one? Okay. Point number 2 here, I said you will need to use IV therapy. We just talked about that. Restarting her medications is a future plan once we control her blood pressure over the next 6 hours. Yes, of course. So IV nitroglycerin looks like a good option with a good target. Okay, let's go back to the case here. IV nitroglycerin with a goal MAP reduction of 25% within the 1 hour, which is what we talked about. This is the goal that we talked about, 20 to 25% reduction in the mean arterial pressure within the first hour or two. So that's a good plan. So what about option number 4, IV enalaprilate with goal blood pressure reduction of 50%? It sounds very extreme because the goal reduction is 50% here. We don't have that goal in any guidelines. Also, it's targeting the blood pressure in general and not the mean arterial pressure. And we should be targeting the MAP reduction, not the BP reduction. The BP reduction is a goal for hypertensive urgencies, not for emergencies. Sublingual nifedipine, we said we don't use that anymore, and here I say it again, it should never be used due to the high risk of cerebral ischemia or infarction, myocardial infarction, complete heart block, and death. And that's basically why we stopped using nifedipine sublingually years ago. but until today, I still see clinicians using sublingual nifedipine. I don't know if you see that in your practice. Let me know in the comments if you still see that in your practice, because this is old class that should stop. And yes, you can always recommend to them to stop using that and give them the rationale. The clinical trials and all the guidelines out there mention how dangerous could be sublingual nifedipine, especially in emergencies. So yeah, let me know if this is something that you see in your practice, or if you ever saw that in the past and it's not an issue anymore. Option number 4, IV enalaprilate, is another valid option. Yes, it is a valid option. However, the goal of BP reduction of 50% within 1 hour is quite exaggerated and is not recommended, of course, because that's not something that any guideline recommends. It's really it's very exaggerated, and we don't want to lower the blood pressure too quickly. The patient will end up in hypotensive status, and then you'll have to manage that. And again, also, if the patient has a comorbidity, if they have a stroke or anything, we have to lower the blood pressure slowly, because you still need blood pumping into the brain. So yeah, be very careful with your goals. 20-25% is just enough in the first hour or two, and then slower reduction thereafter is or should always be your goal. That's all for today's case and today's presentation. Let me know if you have any questions about the management of hypertensive emergencies in clinical practice. And I'm preparing a few other videos that are taking some time, because I'm also talking about guidelines from other countries. So hopefully as soon as those videos are available, I'm going to post them on my channel. And until I do that, I hope you have a great weekend. Thanks for watching again, and have a good day.